Now let's learn about the principles of antimicrobial therapy. Yeah, let's learn about the pharmacokinetics of pharmacodynamics. Let's learn about stewardship. Stewardship includes not only limiting antimicrobial usage inappropriately, but also optimizing the antimicrobial selection, dosing the route and duration of therapy to maximize the clinical cure or prevention of infection while limiting the unintended consequences such as the emergence of resistance, adverse drug events, and measurement of the effectiveness of AMS activities is a key component of ongoing quality improvement. In AMS program, this usually includes measuring the antibiotic usage, auditing the quality of prescribing and monitoring process, and outcome indicators via a set of key performance indicators. The key performance indicators generally focus on quantity and quality of antimicrobial usage, as well as the relevant process and outcome measures. Quantity measures include how much the therapy are going, how much of the therapy is given or are using over time. Example, defined daily doses or days of therapy or length of therapy. Quality measures includes to what extent are our using our antimicrobials appropriate. The process indicators include dose optimization, selection of the therapy, compliance of choice, compliance with the appropriate time, duration, then with de-escalation, then proportion of the restricted usage that is accordance with the guidelines. Dose optimization for certain drugs and for certain patients, drug dosage is determined on the basis of parameters like age, weight, surface area. So this is the example of a case wherein the dose optimization is done for a patient 52-year-old with kidney disease and shows a creatinine 4.5. So using the formula, intermittent dose is adjusted. Adult weight dose dosings should be are different. For example, for vancomycin total body weight, aceclidine it is ideal body weight, and varicomycin is adjusted body. You can refer to the articles which mention about the details of the renal dosing of antibiotics. Are we jumping the gun? The hypothesis was that renal impairment is acute rather than chronic. In clinically, a proportion of patients admitted with infectious diseases and thus impairment results within 48 hours in during this the initial higher dose and it's administered over 30 minutes for antibiotics and first dose of antimicrobials should be full dose irrespective of the patient's affinity. After the loading dose is given, another dose is given that is maintenance dose to maintain the steady concentration to maintain the response to the drug by replacing the drug loss during the intervals. Prolonging patients was associated with a higher clinical improvement rate and lower mortality. It is recommended for the patients with severe infections, mainly for the beta-lactam antibiotics, to achieve duration above MIC and improve. Very important to choose the right dilution. Phosphomycin do not use 0.9% NS for dilution. Use sodium instead, for because of the risk of fluid overload. For amphotericin B, do not use 0.9% NS for dilution. Precipitation forms. Then daptomycin gastrocavin do not use 5% D for dilution. Using the right dose depends upon the site of infection, causative organisms, and type of. The right choice depends upon what is the diagnosis, who is the co-host, what is the microbiology, is there risk of drug resistance, what is your hospital antibiogram, which agent is best suited, and what is the correct dose. General principles are make a diagnosis essential for appropriate treatment, limit the empirical therapy, interpret the culture reports, and use full therapeutic doses. For optimizing the PKPD parameters, loading dose, continue to extend infusions, and complex. Do not treat endotracheal aspirate, CVC catheter tube, bacteria with such common bile duct. Every hospital will have their own antibiotic policy for common syndromes. Depends upon the type of disease, organisms, initial treatment, alternatives, and comments. Checking the compliance with the selection of the agents with the local antibiotic policy is required. What is the timing to the first dose? It's the early appropriate antibiotics should begin within 1 hour after recognition of potential septic shock. Appropriate in vitro activity against pathogens should be considered, and route of administration, dose and frequency, penetration, and sedative should be. Now, how to overcome the barriers? Education of the healthcare professionals through a multidisciplinary approach, medical emergency teams, update the policies, administer antibiotics prior to delays, order all initial IV antibiotics as stat, and administer first dose of antibiotics within 30 minutes. Optimizing the duration therapy can be essentially important because many studies have inpatients which are treated for longer than guidelines recommended. Auditing the compliance for duration according to local policy is required. Complicated UTIs, it depends upon antibiotics. Catheter-related infections depend upon the organ. De-escalation it means reduction in the spectrum of the administered antibiotics to discontinuation of the antibiotics providing activity against non-pathogenic organisms. Discontinuation of antibiotics with similar activity and switching to agent with narrow spectrum is required. Switching from IV to oral is should be considered on priority. Guidance of antimicrobial use as recommended by NICE is depicted in this chart. If in is suspected, administer antibiotics within 1 hour of the policy, take microbiology samples and advise the review at 48 to 72 hours from the treatment. Ensure serum levels exceed the MIC of the pathogens. To compare the ratio of MIC to achievable serum levels, to be aware of difference between in vitro susceptibility and in vivo effectiveness. Identify the ideal antibiotic with same or similar spectrum of microbial activity. Avoid duplications of the therapy. Possible, select a well-absorbed antibiotic and give it in a larger dose than that used in the initial parental regimen, as option for oral administration may be less than optimal in ill patients in hospitals. So, which other antibiotics that are useful in the switch programs? We have IV antibiotics, we have oral antibiotics, antibiotics which are only available IV and oral antibiotic equivalent. So, this table can be referred for the switching program. Research antimicrobial usage needs to be followed. Antimicrobial resistance leads to increased morbidity and mortality. The pre-authorization and restricted use of antibiotics are the key modalities of stewardship program. The list of restricted antimicrobials includes meropenem, colistin, vanco, ticoplanin, daptomycin, antifungals like micafungin, and interfungal and others. Adherence to the antibiotic policy is evaluated and justification of the restricted antibiotics is determined based on the hospital policy.